Hello, everyone, and welcome to our session today. So we'll be talking about menopause updates, including starting, stopping, and duration of menopause hormone therapy use. My name is Catherine Cummings. I'm a facilitator at HealthPathways Melbourne. That's a joint venture between Eastern Melbourne PHN and Northwest Melbourne PHN. I'd like to start by acknowledging country. So Northwestern Melbourne and Eastern Melbourne PHN would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri people, the Bunurong people, and the Wathaurong people, as well as the traditional custodians of all the lands on which you join us from today. We pay our respects to elders past, present, and emerging, as well as any Aboriginal and Torres Strait Islander people in the meeting with us today. So just a couple housekeeping rules. So please keep your microphone on mute. Please ask questions via the question box. So the Q&A will be at the end of the presentation. Also, questions will be anonymous to protect your privacy. Also, just please note that this session is being recorded. So, yep. And also ensure that your name in the Zoom meeting is correct, so fully spelled out. Otherwise, we won't be able to get your certificate for the CPD points. So please do that now. Anyway, I'll pass it over to Dr. Sarah Whitburn.
Hello and welcome, everyone. My name's Dr. Sarah Whitburn, and I'm a clinical editor at HealthPathways. And I recently updated the menopause pathways, which we'll talk about a little bit more in the presentation. I have a very strong interest in menopause, especially in primary care. And so I'm very happy to have you all here to talk today about menopause and menopause hormone therapy. And our speaker today is going to be Dr. Elizabeth Farrell, who is a gynecologist at Jean Hales. And Liz, I might let you say a little bit more if you'd like to around your bio, because obviously I've had the pleasure of working with you, but I don't have your bio in front of me. So Liz, would you like to speak about yourself before I go on to the aims for our session tonight?
Oh, thank you very much. Well, first of all, good evening to everyone. And just to let you know that I'm actually broadcasting from a tiny little bedroom in my daughter's house in London, as I've had COVID. And I haven't been able to return home because my test is still positive, but hopefully I'm leaving on Saturday. I'm a gynecologist, as Sarah said. I'm one of the founders of the Jean Hales Foundation. I've worked in general gynecology and particularly in menopause since 1982, when Professor Lorraine Dennisteen and I set up a menstrual and menopause clinic at the old Queen Vic Hospital in the centre of the city, which of course is no longer there, and continued on to run the menopause unit at Monash Medical Centre until 2016. My only other claim to fame, which I love, is that I go with a group of doctors, nurses, and other health professionals to Mongolia on a yearly basis. But recently, of course, due to COVID, haven't been able to attend there. Thanks, Sarah. That'll do.
Thanks so much. So the aims of our talk tonight is that we want to introduce you to the range of menopause hormone therapy available, how to manage both absolute, but also talk a little bit around the relative contraindications and considerations when starting menopause hormone therapy, how to approach the duration of menopause hormone therapy use and what to consider about continuing or stopping. I'm going to touch on contraception in our middle life and how that is used and how menopause hormone therapy interplays and works together with contraception. And then at the end, I just really want to inform everyone about our update of our menopause and menopause hormone therapy pages, so you know about this and other resources. We will be talking about resources that are useful from Jean Hales and also the Australasian Menopause Society, and how they all work together and can be used for you at your point of care. If you haven't seen MHT before, that's the acronym for menopause hormone therapy, which is the term that is now being used. I'd just like to say a word about terminology. During our talk today, we will be using the terms women and woman. However, I do want to note that our discussion today is also relevant to people with a uterus and ovaries who were assigned female at birth and who may identify as male or non-binary or other gender diverse people. When discussing research or resources, we will be using the terms women and woman as defined by the authors. I want to say thank you so much to Liz, obviously, but also to Jean Hales, who is a national non-profit organisation dedicated to improving the health and well-being of women. And Jean Hales combines research, clinical care and practical education for women and health professionals. And Jean Hales aims to inspire confidence to create a healthier future for all women. And I think that as a practitioner in primary care, I really, really value all the work that Jean Hales does on their information, both for me as a practitioner and also for patients and clients. I find that I'm, recommending this daily when I'm using menopause work. So thank you so much. And we will be talking a little bit about the resources and also the link that we have with HealthPathways and how we sort of refer back and forth. And so hopefully they're all working together for you. So I've mentioned HealthPathways a few times. What is HealthPathways? So HealthPathways Melbourne provides clinicians with a single website to access clinical and referral pathways and resources at the point of care. It's all there on your desktop or laptop, wherever you are working. And as I said, we updated the pathways in January of this year and reviewed them and updated any links that needed updating. And you can see here, we've even added some COVID notes and how COVID and the menopause might interact and things to consider. So with that, I will now hand over to Liz, who is going to talk about the menopause initially, and then go on and talk about the menopause hormone therapy and those aims that we have for tonight. So thank you very much, Liz.
Thank you. Can you advance the slides, please? So let's talk about definitions. I think that there is a lot of confusion at times about the definitions. Premenopause means a woman is still having a regular cycle, but it does have to be taken in context of the person. So, for example, a woman with PCOS may in fact have irregular cycles. That doesn't mean to say that she's not still premenopause, but it basically means normal regular cycles. And when the cycles become irregular, it's usually the beginning. It's the only marker we have to tell us that the perimenopause has begun. Now, there are some women who will still have regular cycles right up until their last final menstrual period. So that makes it a little bit tricky, but the perimenopause is a tricky time. It may be that symptoms will occur, but we have to remember that in the perimenopause, the ovary is producing hormones that may be at a low level, but they can also be very high. And in that time, there is data to show that some women can ovulate twice in a cycle, so their estrogen levels can rise quite high, even higher than what they normally would do in a single ovulatory cycle. There's been some interesting data which has shown that the average duration of irregular cycles can range from 2 to 10 years. On an average, it's about 4 to 6 years. I think that the perimenopause is the tricky part of managing women with symptoms and menstrual issues. And we need to actually work more on developing guidelines in this particular area. Now, when we talk about the menopause, it's used in so many contexts. It's used in a colloquial sense, it's used in a societal sense, but medically, it means a woman's final menstrual period. In other words, it's the last period she has, and the postmenopause starts from 12 months after that final menstrual period. So we know that after 12 months without a period, she is postmenopausal. And once that's happened, women are postmenopausal until the end of their lives. So we have to remember that there is no finite time for when did my menopause happen. My menopause happened when I had my final menstrual period. That's it. 12 months later, post-menopause, all that time, and post-menopause is for the rest of a woman's life. Next slide, please. What about the term surgical menopause? Well, it's induced by removal of ovaries before the expected age. And you saw on the previous slide that the expected age of menopause in Western Caucasian women is about 51.7, so about 52 years of age, but it does vary across cultures. A lot of the cultures in the southern Mediterranean and also in some Asian countries, the final menstrual period appears around the late 40s, not into the early 50s. So when the ovaries are removed, either with or without hysterectomy, then that is a surgical menopause. There is no more secretion of estrogen, but also testosterone, as would normally be present with the ovaries there. Premature menopause means menopause before the age of 40. Early menopause means between 40 and 45. And by 45, about 8 to 10% of women have had their final menstrual period. With premature ovarian insufficiency, which is spontaneous premature menopause, about 1% under the age of 40 and about 0.1% under the age of 30. And there are many causes of POI, a lot of which have not actually been identified yet. And of course, women who develop premenopausal cancers where they require chemotherapy or pelvic radiotherapy may also have an induced premature menopause. Next slide, please. Now, we know that there are many symptoms which are related to the menopause, but the classic symptoms are the vasomotor symptoms and the urogenital. All of those symptoms can be caused by other causes as well, but traditionally, estrogen deficiency is associated with vasomotor symptoms, hot flushes, night sweats, which of course lead to sleep disturbance, and then the urogenital symptoms, which include vaginal dryness. Another symptom that in the Melbourne Women's Midlife Study, which was performed in the original study was in the 90s, showed that joint aches and pains was a very common symptom, and up to about 46% of women experience those symptoms. Formication, which is a bit like ants under the skin, is another symptom that women get. They'll say their skin feels itchy, but it feels crawly, like there's something crawling on their skin. And associated with, of course, the sleep disturbance, the sweats, the flushes, can be difficulty concentrating, irritability, fatigue, anxiety. And palpitations can be associated with the onset of hot flush. Women can feel quite strong heartbeat as they're experiencing the hot flush. And associated with all of that can be lowered mood. And we then have to put it in the context of the woman's psychosocial state as well. So about 80% of women will have symptoms, but 20% will have severe symptoms. And if we look at the data on duration of symptoms, there are a number of studies which show the median duration of symptoms is 8 years, not 5 years. And so therefore, as in WHI, you can stop the therapy. It is not so. And there is also data from Sue Davis's studies at the Alfred that women in their 60s and 70s, there will still be a significant but small percentage of women who are experiencing bothersome symptoms. And there are the lucky 20% who have no symptoms. Their periods stop and life just moves on. Next slide, please. So when we're looking at management, we have to look in a holistic sense. When we're taking a history, we have to make sure that we understand where the woman is in her life, in her social context, what her life stresses are, whether she has any issues with diet, exercise, obesity, smoking, alcohol, all of those things. Does she have a family? What does the menopause mean to her? Are there cultural issues in association with becoming postmenopausal? All of those things are very important. And educating women into the fact that this is a normal life process. Excuse me. Then we have to look at how can we manage women, and that is with hormone therapy. But first of all, we look at all of those lifestyle issues first, and dealing with some of those may help their symptoms. We look at therapies that are both prescriptive, non-hormonal, and menopause hormone therapy, and also complementary therapies. Next slide, please. Excuse me. Now, when we look at the urogenital symptoms, and a lot of women come to see us with low libido, and that's really another topic. But once again, low libido has to be put into a context. If you can't stand your partner, why would you have a libido? So these are some of the things that have to be looked at when you're seeing a woman who presents with genitourinary symptoms of the menopause, which has been a term used since about I think 2015. So vaginal dryness is a consequence of estrogen deficiency. And what we would recommend, particularly in women, say, for example, with a history of breast cancer, that they use a vaginal lubricant and moisturizers to start with. Now, what it says there is most similar in pH, so it's acidic, and the osmolality has not got to be too runny or too thick. It's a very interesting paper published in Climacteric some years ago by Professor Nick Panay from the UK on the pH and osmolality and which products are available on the market that actually fit the criteria. And there is only a very small number of them in reality. Most of the products that are on the shelves in pharmacies may be outside this range. So we recommend water-based lubricants during intercourse, so lots of across-the-counter products, but we can use natural oils. Olive oil, sweet almond oil. The sweet almond oil smells nice, so it's not a turn-off, as it were, but natural oils can be used. Vaginal moisturizers are used in the vagina, and usually they last for about 3 days. So Replens is the most commonly used one in Australia, and that's used on a twice-weekly basis. And it increases the moisture, it brings out the water out of the tissues and makes the vagina moist. Next slide, please. So pelvic floor exercises are very important. But what we have to remember is having overactive pelvic floor muscles, in other words, crunching your muscles so that they never relax, is also a negative thing. And overactive pelvic floor muscles, in fact, may have a negative effect on libido and sexual intimacy and may cause dyspareunia, in fact. So it also, with regards to low libido, it's important to take time, and most people are time poor or they have little time for privacy. And so these are the things that have to be taken into account when we're discussing low libido. Now, some years ago, there was quite a lot of research done looking at phytoestrogens and whether or not they would have any positive effect on vaginal dryness. And some studies that were done originally at the old Prince Henry's Hospital in Melbourne, which is now the Melburnian on St Kilda Road, showed that, in fact, you could increase the secretions in the vagina by using linseeds. And our naturopath, who is also head of our Jean Hale's Kitchen, says that 2 tablespoons of freshly ground linseed, and they should be no longer than 2 weeks old, taken daily, can help to reduce vaginal dryness. And there's a recipe for some muffins on our website to promote the use of linseeds for vaginal dryness. Next slide, please. So what about menopause hormone therapy? I mean, you've heard this every time there's a lecture on hormone therapy. It's well established for menopause symptom relief. There are studies going back to the 70s that have been short-based studies showing menopause relief through to so many other studies, including the WHI, which was really the first randomized control trial showing that it was a benefit. It wasn't meant to be a symptom relief study, but in fact, those women who did have crept in who had their symptoms relieved. It's not recommended for the prevention of disease, and that has been also since the WHI and the PEPI study and the HELP study, which occurred in the late 90s. So not recommended for the prevention of disease, except in premature menopause, where it is essential because these young women are at risk of earlier onset of cardiovascular disease, osteoporosis, dementia, and some evidence about Parkinson's. When we're assessing a woman, we have to look at the risks and benefits, but then we have to put it into context of each individual woman, and that is very important. It depends on the quality and quantity of her symptoms, the impact on her quality of life, and it's about how the symptoms are bothersome. And she is the one person who can tell you that. It's not a judgment that we are able to make as practitioners. And we know that the risks and benefits are going to vary as a woman gets older. Next slide, please. So we know that the relief of vasomotor symptoms in particular, and that's what we're talking about in principle, there is a massive reduction in menopause symptoms with the appropriate effective dose. We know that the WHI showed these aspects. This was the first randomized control trial to show that there was a reduction in osteoporotic fracture. And in women under 60, menopause hormone therapy, if there are no contraindications, really should be the first-line treatment for women who are at risk of fracture or who have severe osteopenia or osteoporosis. And this is something which doesn't necessarily happen. There are a lot of endocrinologists who are unfamiliar with prescribing menopause hormone therapy, and you may see women being put on to Prolia or bisphosphonates. But in reality, menopause hormone therapy should be the first-line treatment in women under 60. And of course, it is in premature menopause. And women who have premature menopause should be on moderate to high dose therapy. You don't put them on low dose therapy, you put them on high dose therapy, higher than what you would normally do in women who have had menopause at the expected age. We also know that there's a reduction in colorectal cancer risk with MHT, and those women who start MHT before the age of 60, there appears to be some cardiovascular protection. Next slide, please. So what to think about when you're prescribing for the menopause? And I think the important thing is that you first of all do your appropriate assessment of a woman and see what she wishes to do. So women will often come saying, I'd like to talk about going on hormone therapy. The idea is not just to pull out our prescriptive pad or do our e-script quickly, but to actually find out where she's at. So what are the contraindications? What are the symptoms that are concerning her? Could they be caused by something else? Now, we know that thyroid dysfunction seems to occur also around the time of the perimenopause. Could they be due to thyroid dysfunction? Does she have a uterus or not? So do we have to prescribe progestogens or not? And when did they stop their periods? What are the impact of other medical conditions they may have? They may have hypertension, they may have obesity, they may have hypercholesterolemia, they may have an autoimmune condition. How does this all impact on how you prescribe therapies for that particular woman? And most importantly, what is the patient's choice? It's got to be her choice, but she has to be given the information. A lot to do in general practice in a consultation time. So long consultation is always better. What we want to do is to start with the lowest effective dose, not the lowest dose. So the lowest effective dose that is actually going to control her symptoms. And that may be a low dose, but it may not be. It may be something that you have to work with over a period of up to 6 months to find what is the correct dose for this individual woman. Next slide, please. So what are the contraindications to hormone therapy? Well, any hormone-sensitive cancer, breast cancer, so we know that not all breast cancers are hormone sensitive, but breast cancer per se is a contraindication. Other hormone sensitive cancers, including endometrial cancer, greater than stage 1. So it would appear that with stage 1, we can prescribe estrogen replacement therapy. There are some other uterine cancers that where MHT is a contraindication, such as leiomyosarcoma and other sarcomas, and there is a couple of ovarian cancers where estrogen replacement therapy is contraindicated. Excuse me. We know that thrombophilias and past or recent venous thrombosis are contraindications, either recurrent thrombosis with either DVT and pulmonary embolus. But there are qualifications for all of these as well. Any undiagnosed vaginal bleeding needs to be investigated and the cause found and treated. Active liver disease is contraindication, uncontrolled hypertension, but not controlled hypertension. And where a woman is at very high cardiovascular risk or has cardiovascular risk disease, this is a contraindication. But as I've said, next slide, please. As I've said, there are always ways in which some of these contraindications may be managed or manipulated to allow the woman to have some form of therapy. Now, estrogen alone is given in women who do not have a uterus, that is, they've had a hysterectomy, except perhaps in women who have had a pelvic clearance with a hysterectomy and their ovaries out for severe endometriosis. And there has been some discussion about what is the correct thing to do, but the European guidelines on premature menopause and endometriosis suggest that the use of estrogen and progestin in those women is more appropriate than estrogen alone. So when we prescribe estrogen and progestins, we're prescribing them in women with a uterus, and we use the progestogen for endometrial protection. It may have a very small role on bone density. It may have a small role in symptom relief, but in the main, it is primarily prescribed for protecting the endometrium against the proliferative stimulation of estrogen on the endometrium. And you can, when you think about the normal menstrual cycle, this explains why we need to use estrogen and progesterone in MHT. You know that the follicular phase of the menstrual cycle is estrogenic and therefore proliferative, and you see an increase in the endometrial thickness. Then ovulation occurs and the ovary produces not only estradiol but also progesterone, and you see that the proliferation of the endometrium stops. And so that we know that progesterone acts as an anti-proliferative effect of the estrogen, and then the endometrium is protected. So we have to make sure that the progesterone dosage that we're giving is endometrial protective, and that may be individual. And we may have to look at that in some particular people. In the main, we can prescribe the standard therapies because they have been trialed to show endometrial protection. In the perimenopause and in the early postmenopause, up to 1 to 2 years after the final menstrual period, we usually recommend cyclic therapy. So that can be, that is continuous estrogen and cyclic progesterone. And there are various different regimens for various different therapies that are prescribed and available. We can also use the levonorgestrel IUD in the perimenopause, and that serves a great purpose because heavy menstrual bleeding may occur because of anovulatory cycles and superovulatory cycles in the perimenopause. So that allows for endometrial protection. It also allows for contraception, and we'll hear more about that later. And it also can be used in menopause hormone therapy. But we have to remember that it doesn't matter which progestogen, there are potential risks with each of them. And we usually suggest that after the first 1 or 2 years that we use continuous therapy. Women, Australian women prefer not to have any bleed. Some other cultures may like to have a period and think that they're more feminine by having a period. They feel more female. Low-dose oral contraceptive in women under 50 is still effective, but as a treatment. But hormone therapy seems to be better on bone density than the oral contraceptive pill, but it is definitely a form of therapy that can be used. And women who have been on low-dose oral contraceptive pill in the perimenopause, this may be a topic that I hope Sarah will look at, when to stop the hormone, when to stop the pill. Tibolone is a synthetic form of MHT. It is a synthetic progestogen, which has the actions of estrogen, progesterone, and testosterone. It has 3 major metabolites, 2 of which are estrogenic, 1 of which is progesterogenic. But it works on a number of different ways. It works according to a genomic receptor site action. It also works specifically on blocking certain enzymes, which allows its progestogen effect to be endometrial protective. And it works on particular tissues. So it seems to have less effect on stimulating breast tissue, but it is still not approved of in women with breast cancer. And TSEC is I've got a menopausal memory loss here, but it's tissue selective estrogen compound of some sort. And it's, in other words, it's a product with conjugated estrogens plus basodoxifene, which is a SERM. And it has, it acts as a progestogen, the basodoxifene, and also has an effect on bone density. Next slide, please. So different routes that you're all aware of: oral therapies, but an increase in the risk of thrombosis with oral therapies; transdermal patch and gel with no increase in thrombosis in studies using up to middle doses. no studies with higher doses. Vaginal estrogen for genitourinary symptoms, and then the intrauterine device for both contraception in the perimenopause and use as a progestogen over the transition and in the postmenopause. Next slide, please. You notice that implants are no longer available and haven't been available for some time. Well, systemic versus vaginal estrogen, they're for totally different indications. So we use vaginal estrogen for the genitourinary symptoms of the menopause, which are the vaginal atrophic symptoms plus the associated urinary symptoms and sexual symptoms which may be associated with dyspareunia due to vaginal dryness. And the systemic therapies are used for the general systemic symptoms of the menopause. They may benefit the genitourinary symptoms, but some earlier studies done with conjugated equine estrogens showed that up to 30% of women may still have atrophic symptoms, and you may have to combine not only systemic MHT, but also a vaginal estrogen. Next slide, please. So making a decision regarding each of these is really, there are different ways of looking at this. The reason why the decision is made is because of the likelihood of breakthrough bleeding. And obviously, if somebody's in the perimenopause, they still may have some sort of cycle and therefore have the potential for bleeding. If we use a continuous combined therapy, we'd use it usually postmenopausally. And, but there is still some increased risk of a side effect of breakthrough bleeding initially in the first 6 months. So it doesn't mean to say that this isn't an appropriate therapy. It is potentially a side effect that can occur in the first 6 months. Sequentially, as we've said, if perimenopausal, if there's ongoing bleeding, and if there's ongoing bleeding over 6 months, you must investigate and check and see if there's a cause for that persistent bleeding on a continuous therapy. She may have a polyp, or she may have a very thin endometrium. And then you could trial her with sequential and see if there's no cause found and see how she goes. We know that any new bleeding that's unscheduled should be investigated. And we can, with some of the, if we're using particular products long-term, we may need to make sure that that the appropriate progesterogenic dose is actually being given to the woman. So there is an increased risk of endometrial hyperplasia over many years if women are continued on sequential therapy. So these are the things that we have to take into account in long-term therapy. Next slide, please. Well, I think we've gone through this really, but perimenopausal, I think that what we have to remember is that contraception is very important. And I think that Sarah will deal with this. But the perimenopause, you can have menopause symptoms, but you can also have symptoms of hyperestrogenic levels. And a third of the cycles are still ovulatory, so there's the potential for pregnancy. And LOOP means luteal out of phase ovulation, which means that some women can ovulate mid-cycle and then they'll have a second ovulation in the same cycle, which will occur during a period. And that is important why contraception needs to take place. If they're going to be on hormone therapy, they should be on sequential, and we may have to use the levonorgestrel for any abnormal bleeding, but also in the postmenopause. So as it says there, postmenopause, you can use continuous therapy or the levonorgestrel IUD and systemic estrogen. Next slide. And then we look at the types of MHT, and the resources are superb. The AMS has a guide to equivalent doses, which looks at those on the PBS, those on the who are non-PBS, and of course it can be a financial consideration. Luckily, the combined patches are on the PBS, but some of the oral therapies and of course some of the gels are not available on the PBS. And progesterone is not available on the PBS, but other progestogens are. I think we have to remember that menopause hormone therapy is not contraceptive. So in the perimenopause, that is very important to remember. Next slide, please. So a lot of women will like oral therapy because it's easy, it's a daily dose, they may have other medications, it's well absorbed, but it goes through the first part of metabolism. So you've got to have a larger effective dose. Women may have more side effects initially with nausea, weight gain, breast tenderness, and there's an increase in the risk of venous thromboembolism, but not with tibolone. Next slide, please. So transdermal, it's convenient. It's weekly or twice weekly, depending on which patch is prescribed, and daily if it's a gel. The lowest effective dose, lower effective dose, as it avoids first pass metabolism. It goes directly into the bloodstream. Less of a tendency for weight gain, breast tenderness or enlargement, but it is dose dependent. And there is no increase in the risk of venous thromboembolism in studies up to 50 microgram patches. It's applied on the lower abdomen or the lower back, and it's important to remember to tell women not to use a moisturizing soap on their skin because it may reduce the effectiveness of the patch and the patch may not stick as well. And then in hot, steamy climates where it's very humid, the patches are less suitable because they don't stick. Next slide, please. Different doses, well, lowest effective dose. So you may start with a woman with a low dose. You may start with depending on the severity of her symptoms and how close she is to her final menstrual period, as to what dosage you would start her with. So with the 17 beta estradiols, you may start with either a cyclic or combined oral therapy that is 1 milligram. And with transdermal, with combined patches, you've only got the 50 microgram patches. So if you're going to use a combined therapy, you can start them with the 50 micrograms, but in some women that may be too much and you may have to cut them. Now, that's not recommended, but we all do it. And we might talk about that perhaps if there's a question. So there's some guidelines that are available and they're listed there on the slide. Next slide. So tibolone, I've talked to you really about it. It's appropriate postmenopausally. It's not used in the perimenopause. It's a synthetic progestogen with 3 active metabolites, and they has a less of an effect on estrogenic effect on breast tissue because it blocks 2 of enzymes in the breast. Doesn't block aromatase, but it blocks one of the dehydrogenase enzymes and another one that's gone out of my brain. And it has a very positive effect on bone density. There was the LIFT study, which showed that half a tablet in women over 65 showed an improvement in bone density. In that particular study, there was an increased risk of stroke. These women all were over 65 when they was into the study. And it is very good for vaginal dryness and improves menopause symptoms. As I've said, it has the progesterogenic effect and it has androgenic effects. So it may improve libido. And what it does do, it seems to have an effect on mood as well. but it decreases SHBG, sex hormone binding globulin, which increases bioavailable testosterone. Next slide, please. As I've said, it reduces osteoporotic fractures, doesn't increase bone density on mammogram. That's another thing. Whereas standard oral estrogen and progesterone will increase breast density, there's no increase in the risk with tibolone. And as I've mentioned, the stroke, that was only from the LIFT study. And consider if low libido is a symptom. It is not on the PBS, and so therefore it's relatively expensive. Next slide. TSEC, there we are, tissue selective estrogen complexes. It's a third generation SERM, and it has an estrogen agonist effect on bone and doesn't seem to have a proliferative effect on the endometrium. So it's used postmenopausally. It's been particularly difficult to get recently, and we don't have any long-term data on breast tissue, on breast cancer, but it seems to have less breast tenderness and less vaginal bleeding. And there is an increase in triglycerides with this TSEC and other side effects. Next slide. Now, the non-hormonal therapies, there have been a lot of antidepressants studied. Initially, venlafaxine was studied, and then desvenlafaxine, but also citalopram and escitalopram. Paroxetine, fluoxetine, and sertraline have also been used, and in the States, there's a low dose of paroxetine, which has been developed for the use of hot flushes, but you cannot use them in women who are on tamoxifen because of the fact that they compete for the same liver enzyme and therefore reduce the effectiveness of the tamoxifen. Gabapentin and pregabalin have also been studied, and I tend to use that quite frequently in my women who present with menopause after breast cancer. It improves sleep, it can reduce flushing and sweating, and we start with a 300 milligram dosage, and we get them to take it early, not to take it just before bedtime, because often they struggle to get out of bed in the morning. And clonidine's been around for decades. In fact, when I first started out in the menopause area in the 80s, we had a 25 microgram pill, which has now gone off the market. The effectiveness of clonidine and the antidepressants is about, well, clonidine's about 50% reduction in hot flushes and sweats, and it's only in those particular symptoms that we're using it for. The dosage of venlafaxine is usually around about 75, and escitalopram somewhere between 10 to 20. I would tend to use escitalopram as my first line rather than the venlafaxine. It's much harder to reduce the dose and for patients to get off it. And we know that one of the side effects of the antidepressants can in fact be flushing and sweating. Gabapentin has up to a 60% reduction in symptoms, but some people will have even more of a reduction, which is fabulous. Next slide, please. Testosterone therapy, well, there's still a lot of debate about testosterone. We tend to not use calculated free testosterone anymore. We do the total testosterone and the SHBG. Testosterone cream 1% has been registered with the TGA for hypoactive sexual desire dysfunction and is used on a daily basis. Usually we would start with either half a mil or a mil at night and check the testosterone level within 3 weeks. And so if they use it at night, then test it the next morning. And look for androgen side effects, which means the dosage is probably too high. We would rarely use it except in hypoactive sexual desire dysfunction, perhaps after a surgical menopause if testosterone levels are low and if testosterone levels are low. There's been an interesting paper recently published by Professor Davis from the ASPIRE study showing that testosterone may have positive cardiovascular effects on in women. Have a look at that paper. It's a very interesting paper to read. Next slide. So how to choose? Well, I think we've really gone through that in the sense that you assess the woman's history, you take a proper history, you look at all aspects of this woman's lifestyle, and then develop a treatment plan for her. Look at transdermal or oral, look at what she prefers, look at what her symptoms are. Start with a low or middle dose. The lowest effective dose is what you want to do, and say that it may take up to 6 months to get the appropriate dosage correct. And if she does have any adverse experience, try and get her to at least, unless it's a severe response, try and get her to take it for at least 2 months and see whether or not her side effects start to settle down. Otherwise, if she's had a previous negative experience, start with a low dose and build up from there. Next slide, please. If we look at urogenital symptoms, so genitourinary symptoms of the menopause, we don't need to use a progestogen if topical vaginal estrogen is the only therapy used without systemic menopause therapy. Now, recently, a couple of years ago, there were some big database studies on breast cancer from the UK published, and one of them stated that there was no increase in the risk of breast cancer in women using topical vaginal estrogen alone. So even though the PI says it does, it's incorrect. We don't need to use an added progesterone. And with urogenital symptoms, systemic therapy, as I've mentioned, may help, but there may be a small percentage in whom you need to combine with the local estrogen. Now, vaginal candidiasis doesn't happen postmenopausally. It doesn't happen in women not on therapy. It shouldn't, unless there are any other factors. In women on hormone replacement therapy and vaginal estrogen, yes, she can get vaginal candidiasis. But in a woman who is not on any hormone therapy, it is rare. Next slide, please. Well, it's thought that there is the window of opportunity, and that's within up to 10 years following the menopause, that the using hormone therapy may reduce the risk of cardiovascular disease. But it is not going to in women women shouldn't necessarily be starting hormone therapy after the age of 60. If they have pre-existing cardiovascular disease, then we need to sought the help of the cardiologist as to whether they think hormone therapy is a contraindication. But we would not start hormone therapy in women over 60, and definitely in somebody who has cardiovascular disease. Next slide.
So I'm just going to jump 2 slides because I've just realized that there's 2 that have been swapped around. So we're jumping 2 and then we'll come back.
Excuse me. So it should not be initiated for secondary prevention. And if we're going to use it, we should use transdermal, and we should do it in combination with regular discussions with the cardiologist and the patient.
Thank you. So we're going to go back again now to talk about our next topic.
Well, breast cancer, of course, is the most emotive topic that we have with women and menopause hormone therapy. Without even taking hormone therapy, the lifetime risk in Australian women is 1 in 8 to 1 in 9. And that's gone down in the last In the 80s, I think we used to talk about 1 in 13 or even more. But we have to put it in context that menopause hormone therapy is not the only risk factor for breast cancer. Being a woman's the first one. And things like drinking 2 standard alcoholic drinks per day over 5 years would be equivalent to being on hormone replacement therapy daily for 5 years, according to some of the studies. The major risk factors for breast cancer are, in fact, dense breasts. That's the primary one, and a family history of breast cancer, particularly where there is a genetic predisposition, such as the BRCA genes. We know that from the WHI study, using Premarin and Provera, and this is where we have to take into context that this study uses hormone therapy that we, in the main, do not use in Australia anymore, increases breast cancer risk after 4 to 5 years of use by an extra 3 per 1,000 women per year. It's very small. And estrogen only, there was a decrease, or there was a trend to a decrease in breast cancer risks. And the long-term studies done, follow-up studies on the women with estrogen-only therapy showed that, in fact, there was a reduction overall in breast cancer risk in the long term. And this then leads on to the fact that the different progestogens will have different effects on breast cancer risk. With medroxyprogesterone acetate, which was the progestin in the WHI, Provera, sorry, I'm using terminology, I should be using the drug name, compared to dydrogesterone or micronized progesterone. We also need to look at the fact that medroxyprogesterone acetate and to a lesser extent norethistérone may also have an increased risk in venous thromboembolism as well. So it's important to discuss both when we're looking at the types of progestins we're going to use. Next slide, please. So cerebrovascular disease, there's no evidence to suggest that it increases, MHT increases under the age of 60. There may be a small increase in risk over 60 on oral therapy. And once again, if you start a woman over 60 on oral therapy, definitely, but we would counsel against starting it unless she's within the 10 years of postmenopause and is very symptomatic. Next slide, please. Okay, so our thrombotic risk increases with increasing age, and you've got the absolute risks there. So it increases also with immobility, lower limb trauma, surgery, thrombophilias, smoking, obesity, travel, all of those things, dehydration. So we know that when we're using oral therapy, there's an increased risk in the first year and an ongoing twofold risk with increasing time. A lower risk with oral estrogen alone, no increased risk with transdermal using standard doses, no data over the standard doses, and no increase in the risk with tibolone. Next slide, please. No increase in patients on combined MHT, but it does depend on the product and the duration. So it's important to make sure that the progestogenic dose in the long term is adequate. And we will not use estrogen alone in women with a uterus because there is an increase in risk. There's also been some studies looking at long cycle therapy where you use estrogen only for 2 months and then use a combined estrogen and progestin for a month. in women with menopause, with progestogen side effects. This has been shown in the longer term to increase the risk of endometrial cancer. So we do not use it. And there's no increase in the use of endometrial cancer with local vaginal estrogens. Next slide, please. Potential side effects, well, highest in the first 3 months, a bit like going on the pill. So try and encourage women to just hang in there. They usually settle. Breast tenderness, breast soreness, and even breast increase. Using some evening primrose oil capsules, 3,000 milligrams a day, may help to reduce that if the woman is concerned about it. And once again, as we talked about before, if the bleeding doesn't settle after 6 months, then and she's early postmenopausal, or you need to, if she's postmenopausal and the bleeding doesn't settle, you need to investigate, exclude any pathology, and then change to a sequential therapy. Initial increase in oral therapy, so important to tell the woman about that. Talk about the progesterogenic side effects. They may, so for example, with tibolone, you can get estrogenic, progesterogenic, and testosterone side effects. So it just depends on how they respond. And if the symptoms are persistent, check that she's taking the treatment properly. Instruct the woman with patches to take them appropriately. That is to change a twice weekly patch every 3.5 days, and to put it on appropriately, and to make sure that it's not crinkled, that it's not lifting off, and that she's not using a moisturizing soap. If there's poor symptom control and she's using the patches correctly, then it may be that too low a dose, or it's not absorbing properly. Next slide, please. These are the guides that are available. The Australasian menopause equivalent doses is just fantastic, and it's updated on a regular basis. So please, if you haven't got it on your software, download it and laminate it and have it beside you somewhere on your desk. Next slide, please. These are some of our tools that we have at Jean Hales. And the menopause tool has recently been updated. We also have a tool on heavy menstrual bleeding, PCOS, endometriosis, and I think there's one more that's gone out of my brain. This tool is online, but also there's a hard copy of it as well, which you can get by downloading or contacting Jean Hales. So it looks at all of those aspects that are there on the screen. Next slide, please. There are limited numbers of randomized controlled trials, but usually they're small numbers and duration. There are some positive studies, limited in black cohosh, and there are 2 available products across the counter that have small studies showing an improvement over placebo. But once again, they're short duration. Women are inclined to use across-the-counter products first and think that they are harmless, and but in fact they should be prescribed appropriately by a trained naturopath. And if you have a look at our data on the Jean Hales website, which our naturopath has looked at and checked. Next slide, please. Bioidenticals. Well, all that means is that these are pharmacy compounded hormones. Doesn't mean that they're different than any other hormones. So what happens is the pharmacies buy the hormones from large pharmaceutical companies, and they buy progesterone, estradiol, estrone, estriol, and then they compound them into either as it's got there, lozenges, creams, or capsules, using various different hormones. They're not approved by the TGA, and they're no different than prescribing anything that a pharmaceutical company has products of. So estradiol is estradiol, progesterone is progesterone. Every single hormone has to be synthetically made because there are no natural estrogen, estradiol available anywhere else other than in the human body. So therefore, every single hormone that we prescribe or that a pharmacy compounds into an individual product is synthetically made. It's expensive, and it is not more efficacious or safe because there's no data, but it is not a better product than what the pharmaceutical companies manufacture. Remember, all synthetically made. Next slide, please. So we would normally review treatment ideally at 3 months. Sometimes we might get women back at 2. And then we go through how she's experienced the menopause therapy. Has it helped her symptoms? What side effects did she have? How is she coping with it? And adjust the dose if necessary. But make sure she has a reasonable trial unless her side effects are inappropriate and you should change the product. But only do that, preferably after 6 months. Get her back at 6 months as well, and don't just let her drop off the perch. I know that every GP is exceptionally busy, but you need to keep following these women up because you need to make sure that they're using their therapy appropriately and make sure that their screening is up to date. It's always a good opportunity to talk to them about cervical screening, mammograms, and their general health checks. Next slide, please. Now, what about duration? So I've talked about the study showing a median of 8 years. So duration of therapy is really depending on risks and benefits. There is no particular time span. So the higher the dose, the longer the duration, the increase in the potential risks, particularly obviously of breast cancer. So it should be consistent with symptom relief. We're talking about the woman's quality of life so that she can function in her normal daily work without being impaired by her menopause symptoms. We don't want to see more women resigning from their work because their symptoms are inappropriately treated or they've been told they've got to live with them. They do not have to live with them. There is always some therapy that will be available for them. We should keep women who go through menopause early on hormone therapy up until the expected age of menopause, which is around 52, and then look at how what the symptoms are. Has she still got menopause symptoms? What's her bone density? What's her cardiovascular risk? Now we know that once a woman has ceased her hormone therapy, she goes back to all of the postmenopausal increasing risks with increasing age of cardiovascular, osteoporosis, cerebrovascular events. So it's balancing symptom relief, quality of life, dosage, and you may be able to, with time, reduce the dosage down and still be symptom-free. I've got some women who take their therapy 2 or 3 times a week, obviously oral, and I say, but why? You may as well stop it. And they say, when I stop, I don't feel as well. Now that's the person's choice. I've got some women who've got cardiovascular disease. Their cardiologists have agreed that they can stay on a low dose of hormone therapy we've tried to cut the dose down. The woman says, I don't feel as well, I'm staying on it. And I have to say, the oldest person I've had on hormone therapy was 98. Next slide, please. So annual review after that. So every time she comes in, you're doing a risk-benefit analysis. Try and see if you can reduce it. I think it's better to wean rather than to go cold turkey. So just a gradual reduction in dose, and we'll see how it goes. Next slide. So this is a tricky question. If someone's got symptoms later in life and they've been on hormone therapy, they've stopped hormone therapy, and they've got a period of time where they have no symptoms, then you must investigate for secondary causes of flushing and sweating. And there is a list a mile long other than menopause. And you have to take those into account. We alluded to it before with thyroid disease, but medications like venlafaxine, all of those different things. So important if they've had a break of symptom-free. If they've not been symptom-free, when they've been usually forced to go off their hormone therapy by their GP, then you look at non-hormonal therapies. But some women will have symptoms that go on for 10 years or more. Next slide, please. Well, I've got through all of those slides.
You did, and you were in good voice, and you did well. I was very impressed. I had the slides here at any moment, but thank you very much. And I am going to take over for a little bit and talk about contraception, as that's one of my special interests. But Liz will be with us for questions, and I am writing down questions as they come into the chat. But I thought I might jump in here because one of my other roles is that I work at what was Family Planning Victoria and is now Sexual Health Victoria. We've had a name change, and contraception, especially in midlife, is definitely an area that we spend a lot of time talking to people about. And I think that what we talk about is, one, when should I stop? I get a lot of questions about that. And I especially get a lot of questions about contraception that may make people amenorrheic in their late 40s and 50s. But I also get a lot of questions about, well, why do I have to take contraception? Because I think a lot of people feel that it's very low risk they'll get pregnant. But as I sort of say to them, it's not no risk. And I think we've talked about that you can have these out of phase ovulations. And I think also at the perimenopause, where it can be high estrogen, low estrogen, or normal estrogen. And I think once we start explaining to people that we're transitioning, that it's a period of time that we need to still have protection, most people are happy to consider their options. And what I tend to say is, though pregnancy aged in that late 40s or 50 years or over is very uncommon, unintended pregnancies at this stage can be very much more higher risk for the person. So it's perhaps not about having a pregnancy that will go full term, but it's more about protecting against conception and some of the risks of that. So one of the first things is, how long do we need contraception for? And contraception remains important until the menopause can be established. So I'm talking about people who aren't on contraception that might mask the last period. So those sort of contraceptions that make you amenorrheic. So the progesterone only contraception. And I'll talk a little bit about that in a minute. But if someone is using a barrier, so say they're using condoms, or they're using a copper IUD, or they're not using anything, someone can stop using contraception if they've had 2 years of amenorrhea if they're under 50. So if they're 48, they need to have had no period since 46. Or if they're over 50, they have to have 1 year of amenorrhea. So really looking at 51. The other thing to think about is by 55, most people have stopped ovulating. So these are these numbers that you can think about. If you're under 50, you need at least 2 years of amenorrhea. If you're over 50, you need 1. And at 55, you probably don't, you won't need contraception. So they're just things to consider. But I wanted to talk about contraception in general. So for people who are in their 50s or over 50s, the combined pill and the vaginal ring are not recommended. So I do have a lot of people who are on the low dose pill. They turn 50, it's helping with their menopausal symptoms, it's giving them contraception. However, we have to have the discussion that their risk of venous thromboembolism and arterial disease has increased. And it's time to talk about that. We don't want to not treat their symptoms, but we need to consider how are we going to cover their contraceptive needs and their symptoms without putting up their cardiovascular risk. The depot injection is not recommended from age 50 and definitely should be considered carefully from 45 and above, because of its impact. It makes you very hypoestrogenic, and so bone density concerns and the theoretical increased risk of arterial disease. So if you're not already thinking about other options in the late 40s, by 50, that should also be stopped as well. So the long-acting progesterone-only contraceptions is really still a very first-line choice. So that's the implant, the hormonal IUDs are definitely something that you can use. And progesterone-only contraception, they can continue their method until they're 55. If you are using these products, often you lose that last period, and so people tend to be amenorrheic. So if they're amenorrheic, they're using their implant, then we decide that we'll take it out at their 55th birthday. They still need to be replaced as licensed. So if someone's using an implant, then it needs to be changed every 3 years up until 55. If someone's using the lower dose levonorgestrel IUD, which is the 19.5 milligram, trade name Kylena, it still needs to be replaced every 5 years. If someone's using a 52 milligram levonorgestrel IUD as contraception or menstrual management, and they're not using it with extra estrogen, they're not using it for menopause hormone therapy, once it's been inserted over 45, that is the only hormonal IUD that can be left until 55. So it could actually be left for 10 years. A lot of people might have heard the 7 years, but if they're just using it for contraception and menstrual management, it's actually up to 55. You can set the 55th birthday, say happy birthday, time to take your IUD out. However, as we've mentioned, the 52 milligram levonorgestrel can be part of your menopause hormone therapy and can actually provide endometrial protection. It is worth noting that, and I often will write in my notes, if someone starts to use it for contraception and menstrual management and menopausal therapy, that I note when they've last had it changed over, and I start to put a comment or whatever medical software to say, hang on, this person is using an IUD and they're using it for menopause hormone therapy. I need to think, is this within the 5 years? Do they need to have another change? So I think that's just the only thing, if you are working with people with IUDs, is I always say if they're thinking about having hormone therapy, that really they should come and have a chat so we can figure out where they are in their cycles. A lot of people will say, well, how do I know if somebody wants to remove their contraception earlier than 55 for whatever reason? And you'll see that there's a chart here, and this chart is available both through, we have an over 40s contraception resource on the Sexual Health Victoria professional clinical resources, but HealthPathways also links to the same resource. So this is available in those two ways. So if someone is over 50 and they didn't want to wait to 55, as I spoke about, but they wanted to have their contraception changed, I think the first thing is, as you can see here, if they're on the depot or the pill, then really we're going to recommend that they change over to the progesterone only or a copper IUD or a barrier. If they are actually wanting to stop their progesterone only, then they can have a blood test. And this is probably the only time that we would consider using a blood test, looking at follicle stimulating hormone, looking for that to help us identify where people are in their reproductive life. But this is actually not to diagnose the menopause. It's really about diagnosing, are we past that fertile time? So if somebody has been amenorrheic on a progesterone only for at least 12 months and over 50, you can check an FSH. And if it's above 30 units per litre, they've still got to have their contraception for another 12 months. So I often bring out this chart. I actually think with all these numbers, it can be very hard. So I actually recommend having this chart and working your way through it. If, however, they're under or equal to 30, they actually need to continue their method and have another blood test. So that's not to remove it in 12 months. So if someone's 51, oops, we're going too far. If someone is 51 and they've got 20, their FSH is 28, they need to keep going with their implant for another year and then have the blood test again. So I often work with people and talk about leaving it till they're 55, as long as they're not having any side effects, because you can remove it without the blood test. I get a lot of questions about what if somebody has an implant or is on the progesterone only pill, can they use that with their menopause hormone therapy? The answer is no. The only ones you can use is under 50 is the low dose pill, or the 52 milligrams levonorgestrel IUD. You can't use it as well as your menopause hormone therapy, but you could add in menopause hormone therapy. So if someone's really liking the implant as their contraception and they want to have menopause therapy, they can, but you've got to have it as a separate therapy. So I do have some people who are using a combined patch but have the implant. I must admit, a lot of people quite like the idea of having the IUD, and many people will move over to the 52 milligram levonorgestrel IUD and then have estrogen to manage symptoms, especially if they've had a lot of irregular or heavy bleeding. It's a great way to manage that transition. So thank you. That's all I'll say about that, but very happy to take questions. And as I said, I would recommend looking at these resources and going through the flowchart, because it's, with all the numbers, I always think it's good to have that in front of you. So we've mentioned resources many times, and I've also mentioned HealthPathways, that many of these resources can be linked to, specifically Jean Hales and the Australasian Menopause Society, especially the list of menopause hormone therapy. But I can also recommend the North American and the International Menopause Society. They also have webinars and great information. So it's often useful to be looking at our colleagues in other parts of the world as well. And I'd just like to finish our presentation today about how to access the HealthPathways, which will also, as we said, really does link you with some of these resources that we've been talking about, as well as having a lot of the information we've talked about today in a very accessible way of working through some of these choices and some of the different types. If you log on, this is what you'll see. This is our new mobile site, the Melbourne HealthPathways. If you want to find the menopause page, you just do that in the search at the top there, and you can see that you can find pathways, clinical pathways on menopause hormone therapy, as well as other topics that are relevant. So as I've said, we've got our new pathways. I think the thing that I'd really like to highlight is that it does link via the non-acute gynecology referral page to menopause clinic details, such as our hospital colleagues and Jean Hales and some of our other colleagues who are working in this space. And if you have any resources or clinics that you think would be useful for primary care, or you'd like to see any improvements or changes to the page, you can send feedback that will come to us and we can take that into consideration. So thank you very much for joining us tonight, and I hope that you'll be as enthusiastic about the menopause as we are now for your patients, and we'd be very happy to take questions, and we can see that in the chat, so I'll stop sharing that at the moment and make sure that I've got the chat up. Please consider your questions. We've got one already that I thought we might start with while people are typing in the chat. So it's a very interesting question, Liz, which is, given the vaginal estrogen has different risks to perhaps systemic menopause hormone therapy, do we think that vaginal estrogen would ever be available over the counter without a prescription? And the reasoning for this for our colleague is that often people could benefit from a short course of vaginal estrogen prior to something like an examination or cervical screening test, but find barriers to going to the GP, either that's time or cost or maybe gender or embarrassment. I think that's a really interesting question. I am going to put it to you, but before I hand it over, I would say as a vulval medicine GP, it is good to have an examination and exclude other causes for discomfort. So I do like having someone come in and have a vulval examination and education, especially about genital skincare. But interesting thought. What do you think, Liz? Would it ever be available without a prescription?
I don't know is my answer, to be honest. I think the use of vaginal estrogen by women is still not well understood, or the education around it is still not good. And so I think that we would need to have a lot more education around the use of vaginal estrogen. When you use it, it's not a lubricant, all of those things, and not yet is my final.
No, and I think also, obviously, I do think vaginal estrogen can be useful for cervical screening, but I do think, and we've touched on it a little bit, but and there are some great resources on Jean Hales, and once again, HealthPathways also links to some of these resources, is improving genital skincare can make a big difference. I've seen people with emollients and lubrication really make a huge difference before we've even given anything on prescription. So I think having that chance to talk about it, perhaps even being proactive. And I know if I've ever seen someone, and I know cervical screening is now 5 years, and it'll be interesting to see how self-taken screening that comes in later this year is going to impact on this. But especially my people that I'm seeing at midlife, if I say I identify that they're due for cervical screening in about 6 months, I kind of actively say, have you had any problems? Have you ever found it uncomfortable? Are you having any problems with vaginal dryness? Which I often just use a very open question and just say, you know, I ask everybody this. Sometimes in our 40s and 50s, we can have dryness or pain or discomfort. Has that ever happened to you? And that can really open up the discussion. And often it's a proactive. I say, oh, well, have you thought about using vaginal estrogen before we do the cervical screening? Here's how to use it. So I think just picking up on this, sometimes if you have someone there, being a little bit proactive might help with that increased uptake for the right person. But yes, I really like the chance to be able to talk to people about vulval health. And so I like people to come in so I can do some education. Any other questions? Nothing much in the chat, but I'll give you a little bit more time. Liz, I've always wondered about tibolone in the perimenopausal. I understand it's mainly about bleeding. I know a lot of people come in and ask about it with libido. I guess in that transition, any thoughts around low libido, besides obviously really having a good history and thinking holistically?
Look, I think the important thing about perimenopause is that it's a time of vulnerability. It's a time where we've got so many changes happening in our bodies that it does tend. I think libido has to be taken in terms of context, and I don't know that I would even consider tibolone for libido in the perimenopause. I think there are so many things going on in women's lives in that transitional phase that I think we have to put her life into her context, and then see how we can help from the practical point of view rather than from necessarily a pharmaceutical point of view.
Thank you, Liz.
I just wanted to make one comment about the fact that on the health professionals part of our Jean Hales website, anyone can send in a clinical question for sort of ask a doctor, as it were. If you've got any tricky patients that you're unsure of, or you've got some issues, you can always send in a question, and one of our team will answer that and put it back on the website. So please remember that there's always that capacity to seek some clinical help.
So we have one more question, which I think will be our final question for tonight. So our colleague has asked, many women who are on treatment for breast cancer have severe symptoms menopausally, particularly hot flushes and vaginal dryness. Is vaginal estrogen an option for these women given the low risk?
It's a very, very good question. And there are two ways of answering that. One is it depends, first of all, on their treatment. So the first thing is if they're on tamoxifen or an aromatase inhibitor. If they're on tamoxifen, vaginal estrogens can be used in conjunction with tamoxifen. If they're on an aromatase inhibitor, I've just got a visitor from my granddog who's Frida the beagle.
Well, dogs and Zoom, that's always good.
And so vaginal estrogen can be used. It seems that there's more data on the use of Vagifem because it shows that the amount of estrogen that gets absorbed over a 12-month period when a standard dose is used, so that's daily for 2 weeks, then twice a week as a maintenance, the amount of estradiol that's absorbed over 12 months is 1.14 milligram for 12 months. It's a very, very, very low dose. So it's minimal absorption. So there's that data on Vagifem, vaginal estradiol. Whereas with the estriol cream and pessaries, I think the estriol cream coats the vagina better initially. So sometimes I will use that as a trial, and then if they're happy with that, we can switch to the Vagifem if needed, twice a week. If a woman's on an aromatase inhibitor, there's still no real data about the use of vaginal estrogen, and most breast cancer specialists or the woman's team will be not terribly pro using vaginal estrogen. They will recommend that she trial the lubricants and the vaginal moisturizers first. The question of symptoms, I outlined that I would use escitalopram as a first line or gabapentin as a first line for flushing and sweating, but it's not going to do anything for the vaginal dryness. So there's still concern and controversy about the use of vaginal estrogen in women on aromatase inhibitors.
Thank you so much, Liz. And I'm just going to stop there now. And thank you everyone for attending the session. Thank you, Liz. I really appreciate you calling in from London within your recovery. Once again, it's always lovely talking to you.
Thank you.
But there is a quick link to complete a brief survey if you would like. And as I said, everyone who's registered, once the recording and the slides are ready in a usable form, we will get that to you. So thank you so much for joining us, and I wish everyone a good night.